Hi, it's Dr. Steve Weiner, and I'm going to talk to you about the devastating complication of blindness associated with fillers. This is going to be a large review of the literature, and I'm actually going to come out with a protocol called No Vision Protocol at the very end. So this should be very informative. It's going to be very long, so take a seat. We're indebted to Blindness and Crothers, who've written 2 papers, and they wrote one that showed all the reported cases up to 2015, which were 98. And then they did a second paper recently published September 2019, about 2015 to 2018. There were 48 cases. So as you can see, there were 98 cases in a little bit over 100 years, and then there are 48 cases in 3 years. So that means that the incidence is increasing or there's more reporting. The other thing that you're going to notice is that the earlier cases were more associated with glabellar injections, and the newer cases are more associated with nasal injections because there's more injections in the nasal area now. So there is also a predilection between countries, and they're mainly in Asia, Taiwan, Thailand, China, and Korea. And that's because there's a lot more injections in the central face, in the nasal, glabella, and forehead area than they do in other countries. But the US is ever increasing. So the differences between the early study and the late study: the early study, as I stated before, the glabella was the most common area and the nasal area was second most common. But now the nasal area is over 50% and the glabella area is about a quarter, 25%. So it's decreased. The forehead being 18%, nasolabial fold 14%. Again, if you add all these up, it's over 100%. That's because in some patients, they were injected in more than one area and they couldn't tell which exact area that the injection that caused the blindness came from. So why are these areas more common than other areas of the face? It's because they're close proximity to the eye. So the HA doesn't have far to go to the eye to cause this blindness. So this is a great study, and this was done by Di Lorenzo, Colin Acevedo, and Woodward. Hi, Julie. This study looked at the volume of the supratrochlear artery from the glabella to the orbital artery, okay? And they did 12 arteries, 6 faces. And what they found was that the average was 0.085 millimeters, but it ranged from 0.04 to 0.12. And you could see all the different measurements down here. So what does that tell you? Well, you have to go by the smallest one. The smallest one was 0.04. So that means that your injections have to be less than 0.04 in the areas that are at high risk to prevent the HA to go retrograde into the ophthalmic artery. So in general, the recommendations are to inject in aliquots of 0.025, and you're going to be a little bit safer than larger aliquots. So let's go back to those 2 papers by Blindness and Crothers. What they found was that in the earlier study, most of the problems were related to autologous fat, with HA being only 23%. Now, flipped around, it's 81% hyaluronic acid, and that's actually, fortunately, a reversible product where autologous fat is not. And then you had calcium hydroxyapatite being 5%, and PLLA autologous fat were 2.1% each. So the majority is HA in the last study. So there's a huge debate always in the literature, what's safer, cannula versus needle. Well, unfortunately, only 33% reported in the second paper what type of instrument was used. So there were 10 cases with needles and 7 cases with cannulas. The cannulas were anywhere from 23 gauge to 27 gauge. So in a separate paper, 17% of vascular occlusions were attributed to cannulas. Now, there are people that think that that is basically over-reporting, sort of a CYA saying, well, I used the cannula and I still got an occlusion. So that's kind of up for grabs, whether 17% is an actual number or actually a high number. So what's the mechanism of occlusion? Well, it's always a retrograde progression of the HA filler through the arteries. Now there's multiple arteries that can cause this. Supratrochlear, supraorbital, zygomaticofacial, zygomaticotemporal, angular, dorsal nasal, deep temporal, infraorbital, and superficial temporal artery are the more common ones. So it enters the ophthalmic artery and then goes antegrade into the central retinal artery or the posterior ciliary artery. So I'm going to show you a diagram on this. If this filler passes into the internal carotid artery, you can actually get central nervous system problems, i.e. stroke. And that happens between 18 and 25% of these cases. So here's a diagram showing the vasculature around the eye. And there's a communication between the external system and the internal system. And that's where you get the HA filler going from the external system into the internal system. So it's a retrograde propagation of the filler into the ophthalmic artery. So here's an example of injecting the angular artery or the dorsal nasal artery, and the filler goes posteriorly into the ophthalmic artery, which is right here. And then the pressure from the artery causes the filler to flow antegrade, and it goes into the central retinal artery and causes an occlusion, or it goes into the posterior ciliary arteries. This is just one other diagram showing a very similar thing. So this is an injection into supratrochlear or supraorbital artery, and this is an injection into the angular artery or the lateral nasal artery. Again, they go retrograde into the ophthalmic artery, and then they transfer into the internal carotid artery sometimes, or they go into the central retinal artery or the posterior ciliary arteries. The clinical features in that second paper were complete visual loss, and I'm talking about bilateral in majority of the cases. Unilateral visual loss was 45%. 18% had CNS involvement, but there were no deaths in this paper. So pain, periorbital pain and headaches were the most common presenting feature. Skin changes, modeling like a typical skin vascular occlusion, was in 43%. Ophthalmoplegia, which means the movement of the eye was impaired, in 54%, and there was ptosis in 50%. Nausea and vomiting in 16%. I don't know the people that had nausea and vomiting and their CNS involvement, but I would suspect that that would be correlated. So the outcomes were 20% had recovery of vision. Partial recovery was in another 16. So you had about 37% improvement in vision with treatment, but 52% had complete loss. In the early paper, only 2% recovered. And the suspicion is that the HA percentage was very low in the early paper, so the reversibility was less. What is the chances of actually getting blindness or visual related changes with your filler injection? So what they did is they stratified 48 cases between this time period, and they figured there was approximately 9.5 million cases. They also adjusted for what they felt was underreported. So they said the chances are estimated to be about 1 in 100,000 injections that you have a case of blindness or visual changes with your filler. So I'm going to go through this very rapidly because these are all unproven techniques, but they're suggested by multiple papers. And ocular massage is probably the most common, and that helps to dislodge the filler and allow for better flow, and aspirin. But there's all these other types of mechanisms to try to lower the pressure within the eye. And if you lower the pressure within the eye, there's going to be higher blood flow to the eye. Here's another sort of summary, and it talks about giving nitrates. And this is a vasodilator and breathing into a bag. All these things increase the vasodilation, hyperbaric oxygen, ocular massage, anticoagulation, and so forth. Again, these have been not proven, so I'm just showing you what is in the literature. There is a debate about when is the critical time period that you have to treat these problems, okay? And I really think that this study is important. In the prior studies, they showed that in animal studies, you can have up to 90 minutes before you get permanent visual loss associated with occlusion from filler. However, this study stated that the monkeys were given barbiturates, which is neuroprotective, which means it protects the eye as well as the brain. They also stated that the clamp on the central retinal artery was at the dural entry, but there are collaterals, meaning there's flow of other vessels that go beyond this that could actually feed the retina. So they criticized the prior animal studies. They also said that the monkeys were likely hypothermic, which means that their temperatures were lower. That happens when you go into anesthesia. So that is also neuroprotective. So now their argument is actually for a lot less time than 90 minutes. And this is their argument. The retinal ganglion cells are considered part of the central nervous system. And the central nervous system has only 12 to 15 minutes before you have progression of a significant infarction, death of the cells. So clamping of the temporal artery when you're doing surgery for aneurysms that leads to a neurologic deficit 80% of the time if it's greater than 8 minutes, okay? The retinal tissue oxygen consumption is greater than the brain, so it's more sensitive to being deprived of oxygen than actually the brain is. So there's oxygenation from the anterior aspect of the eye is insufficient. So even if you adjust for oxygenation from the anterior portion of the eye, it doesn't go back to the retina. So they're proposing that you need 12 to 15 minutes before there is actually permanent damage of the retina. So there's possibly a little hope after 12 to 15 minutes, and they mention this. It might not be a complete retinal occlusion. In that case, you still have a little bit of blood flow. That means you have more than 15 minutes. There could be a spasm or breakup of the clot, so that will give you more time. If there is still collateral intermittent flow, the timing will be prolonged. But we have to shoot for 12 to 15 minutes, I think. The gold standard for vascular occlusion of the central retinal artery is retrobulbar injections of hyaluronidase. Okay? This is routinely performed by ophthalmologists to do blocks. It's at the best access is at the junction of the lateral 1/3 with the medial 2/3 along the floor of the orbit. You advance the needle along the floor while the patient is looking superior and medially. After 1 to 2 centimeters of advancement, the cannula is past the equator of the globe and the direction is changed to a 30 to 45 degree, and it goes medial and cephalad, superiorly, nasally. And you advance it to about 2.5 centimeters, which is the length of a 25 gauge, 1.5 inch needle. You do a negative aspiration and you inject between 1,500 and 3,000 units, okay? Pretty complicated. There's a lot of complications associated with this type of injection too. Retrobulbar hematoma or hemorrhage. What can that do? That could actually worsen vision. You could perforate the globe. You can actually cause an occlusion. So there's a lot of problems that you can have in related to this type of procedure. And it's 3%, which isn't an insignificant number. So my problems with the retrobulbar hyaluronidase is that most injectors are not proficient with this injection. And complications can occur that make this problem worse. 1,500 units of hyaluronidase is 10 cc's. Okay, 10 cc's can lead to compression of the vasculature within the eye. Okay, and there's no conclusive evidence that this has worked. There's only a small portion of the central retinal artery exposed in the orbit, and this is very important, and I'm going to elaborate on this in a second. So there's only about 5 millimeters of the central retinal artery that is actually exposed within the orbit, 5 millimeters. Most of the central retinal artery is covered with dura, and hyaluronidase is not going to transfer through dura and through the arterial wall. That's not going to happen. So does hyaluronidase diffuse through artery? Okay, there's arguments on both sides. Di Lorenzo has a study, and I love Dr. Di Lorenzo, that shows the hyaluronidase rapidly going through the walls of the artery and dissolving HA within the artery. However, this was done on cadavers. The basement membrane of the artery changes within 15 minutes of death. De Lorenzo's high-dose protocol, which was published in the Aesthetic Journal 2017, everyone should read it and everyone should memorize this, and this should be part of your emergencies. The dosing is between 450 and 500 units per area. One area is considered approximately half an upper lip. You repeat it every 60 to 90 minutes until you get clinical resolution of the occlusion. It usually resolves after 3 or 4 injections. He argues against intravascular injections because then you're only treating a small cross-sectional area. And if you're not able to get beyond the area of occlusion. So this is a very important abstract. It's yet to be published. It was presented at the ASAPS meeting in 2019. And it kind of goes a little bit against Dr. De Lorenzo's theories. Okay, so it's by Dr. Tim Papadopoulos, Hema Sundaram, as well as Mark Magnuson. Okay, and it was performed intraoperatively on abdominoplasty patients. And they tied off the arterioles, injected them with filler, 0.3 to 0.5 cc's. And those were similar in size, in diameter, 1 to 2 millimeters of the ophthalmic artery. And what they did is they placed exogenous hyaluronidase and they bathed these vessels, and actually there was no change in the HA within the artery, okay? So this is a live artery, not a cadaver artery. So interluminal hyaluronidase rapidly degraded the HA filler. So this is a little bit different than Dr. De Lorenzo, and this is where I'm going with all this. Let me go through the literature about successful cases of reversing or partially reversing blindness. So there are 4 cases of filler-related blindness by Dr. Zhu. He treated him with retrobulbar hyaluronidase, and the dose was 1,500 to 3,000, and he did it 1 to 2 times. All patients were 4 hours after their symptoms. None had lasting improvements, okay? So there's other similar reports of this too. So you can criticize the problem with this was, number 1, it was 4 hours. Number 2, possibly it was related to retrobulbar hyaluronidase. We don't know. There's also cases, and I didn't mention them in other slides, of actually doing arterial injections with angiography. But those were all done late as well, several hours later. So those cannot be included in arguments for or against, because as I told you, we're looking at now 15 minutes as your upper limit. So this is an extremely important phenomenon that you have to know about. It's called the choke theory, choke phenomenon by Ian Taylor. And basically the face is divided up into angiosomes. Okay, and each angiosome has an anastomosis to the angiosome next to it. Each angiosome has either a true or a choke anastomosis. A true anastomosis, the blood flows freely between one angiosome and the other. However, in the choke anastomosis, there's variability. They can actually close off the anastomosis, okay? So HA within a vessel is inflammatory. In the choke anastomosis, the choke closes up and prevents progression of the HA filler through that anastomosis. In a true anastomosis, the HA flows freely, uninhibited, until a choke is reached. There's also ways with this choke phenomenon to shunt from the arterial to the venous system to try to get rid of the HA filler. So the choke phenomenon, actually what is supposed to be protective, can actually cause necrosis and blindness. So this is something that needs to be addressed when you're addressing blindness or even occlusion. You need to dissolve the area that is suspected of the choke. So Dr. Chestnut, he reported, and it's been widely publicized, a report of reversing blindness, okay? The injection of the filler was in the infraorbital area. 20 minutes after the procedure, the patient had subjective visual loss. They did not document exactly what the visual loss was. He injected Hylenex 150 units in the infraorbital area, in the area of the initial injection. I highly recommend doing that in all cases. He then injected into the supratrochlear and supraorbital areas, 150 in each of those. He tried to cannulize them. He wasn't sure if he did or he didn't. Then he used a 27 gauge needle, 1.5 inch, in 3 separate occasions and injected 150 units of hyaluronidase in a retrobulbar hyaluronidase technique. The vision returned after 2 injections. Okay, he is very comfortable with these retrobulbar injections. He does that with his surgery. So what actually caused the reversal? We don't know, because he injected into the supratrochlear and supraorbital as well as the infraorbital area. He wasn't actually the person who did the injection in the infraorbital area, but he was referred by someone within the building or very close by. So this person was treated almost immediately. So Dr. Goodman, an Australian, reported visual loss reversal with this technique. So he was injecting, or his colleague was injecting, the deep temporal and brow area. The patient had a flashing sensation with ipsilateral visual loss. So 375 units of hyaluronidase was injected in the exact same area that the injections were. He then injected 300 units twice into the supratrochlear area and the supraorbital area, and the symptoms resolved almost immediately after second injections in these areas. So this is another paper of successful improvement in vision. This is out of Korea. So this doctor injected 2 mLs of HA filler into the nasal area. There were skin changes and visual changes associated with the injection. Hyaluronidase was injected into the nasal and glabella, as well as retrobulbar injections. But he noted changes at 20 days and not immediately. So were those injections actually successful, or did they just have improvement regardless of the injections? We don't know about that. It's very suspect that the improvements came at 20 days. Okay, here's another paper. The injections of the HA were in the glabella and nose. The patient had immediate pain and headache, followed by diplopia, double vision, inferior visual change, and skin ischemia. He presented 12 hours after the injection, and the patient was treated with 60 units of hyaluronidase in the subcutaneous tissue and nose and glabella, and at 2 weeks had complete recovery. So what I get from these last 2 studies is that there are going to be some people that probably respond with or without therapy. Okay, I don't believe that 60 units 12 hours later actually caused the improvement. So how about injecting intravascularly in the area of occlusion? Because clinically we see rapidly dissolving of HA almost immediately upon injection of hyaluronidase on a petri dish. But De Lorenzo says it actually takes 15 minutes. Well, 15 minutes, then you're kind of at the limit of whether it's going to be successful or not. He states that the clot might preclude the effectiveness of the hyaluronidase. So if you're injecting in the vessel and there's a clot, it's not going to propagate beyond the clot and hit the hyaluronidase. He feels there's too small a surface area. So if you treat external to the vessel, you have a large surface area of the entire vessel. But if you treat within the vessel, that cross-sectional area is less. That's his argument. So the half-life of hyaluronidase is only between 2 and 5 minutes. And I think it's around 3.5 in a piece that I read. So there is some success with hyaluronidase and urokinase, but treatment delays analysis of the effectiveness. So really, to get all that set up, get transported to the hospital and so forth, it's very difficult to get it in a timely manner. So that's probably impractical to do. So there was a suggestion, why don't you just give it like an IV, do a systemic course of hyaluronidase. Dr. McCann said that in the 70s, hyaluronidase IV was given for myocardial infarctions at 500 units per kg. In pediatric oncology, they go up to 7,000 units per kg. So her proposal is actually 200 to 250 units per kg. So it's a lot less. Theoretically, after you do the math, she got to 3 units per ml of the blood. And the half-life of the circulating hyaluronidase is between 2 and 5 minutes. So it's possible, and they really have no side effects because these higher doses were safe in these patients, particularly pediatric patients. So it's theoretic to give it IV. It's never been done. It's just proposed by Dr. McCann. So what I'm going to go through is something where I came up with a no vision protocol. Okay, so the first N and O are notify ophthalmology. You got to get ophthalmology involved right away. V for vision, visual exam. You got to do acuity, extraocular movements. You got to check the pupils and you got to check the surrounding skin. I, inject hyaluronidase into the injection area and any possible area of choke. Okay. S, go for the supratrochlear, supraorbital, superficial temporal artery. You can also cannulize the facial and angular arteries if you need to with ultrasound guidance. So ultrasound could be used for this as well. If you're still not having success, I would rather have a small little scar on my skin than be blind. So I tell you to incise to gain better access to these vessels. O, as a last resort, do an open forehead, a hemicoronal incision to get to the supratrochlear artery, okay? And then you do numerous vials of hyaluronidase. 500 units over 5 minutes, I don't know. I'm not gonna tell you that because this is all proposed, but just flood the crap out of it. So, Dr. Goodman and Magnuson were part of a consensus paper, and I highly recommend that everyone see this as preventative measures to prevent this devastating problem. This was in the Aesthetic Surgery Journal 11/2019. This isn't all from that paper. There's also some additions that I've added. So when you're injecting in these areas that are at high risk, I would suggest a very easy filler to dissolve, one that's not a lot of cross-linking, obviously an HA filler. So reversibility of the filler is very important. Also do the low injection volumes as I alluded to previously. Do slow injections at bolus because that low pressure is less likely to go retrograde. Is needle size important? They think so. They think the larger the needle, the more likely you're going to be injecting large volumes, more likely to go retrograde. So a smaller needle is probably preferable if you're using needles. Cannulas. There's a question of the safety of cannulas. My preference is for cannulas over needles. Cannulas are definitely not less safe than needles. They're at least as safe. So do not use a cannula that's 27 gauge or smaller because those are the same entry force into the arterial vessels as a needle. So avoid 27 gauge cannulas in the high risk areas. I'd like to use 22 in the high risk areas if I'm doing anything at all. Be perpendicular to the known vessels. Okay, there's a recent paper that actually contradicts this, but I don't believe that. So if you're going perpendicular to the vessel with your cannula or needle, it's very unlikely that you're going to be in that vessel for a long time. Are you more likely to pierce it, like this paper says? Maybe, rather than going parallel, but you're less likely to inject a large amount of filler if you're perpendicular. That's the reason behind this. Obviously, constant movement is better than bolus, okay? Do you aspirate? This paper said there's no conclusive evidence that aspiration gives you any good data. So they did not actually recommend aspiration. I think that aspiration is only good if you're bolusing and injecting the exact same area, and that's rarely done. So this is kind of controversial, but I'm going to throw it out there. Compressing the medial orbital rim and lateral nasal wall when you're injecting into those high-risk areas will prevent the filler going retrograde through the supratrochlear. Also, they suggest small syringes because you have better control over the volume with smaller syringes rather than larger syringes. So this is my disclaimer. The no vision protocol is merely a suggestion and has never been tested clinically. While retrobulbar hyaluronidase is considered the standard of care, successful visual improvement using this technique has not successfully been borne out. Timing of treatment appears to be very critical. 15 to 20 minutes, the visual changes are irreversible. The dilemma: while hyaluronidase clinically appears to work within seconds, Dr. De Lorenzo suggests it could take up to 15 minutes to work in vitro. Filler-associated blindness appears to be an extraordinarily difficult clinical quagmire, and we need to start thinking outside the box with our protocols. The industry is indebted to Dr. De Lorenzo for his work with hyaluronidase and vascular occlusion, and I have the highest respect for him. So my final thoughts. Filler-related blindness is unfortunately an increasing problem. It's estimated that there are 2 to 3 episodes per day worldwide. There are no clinically proven therapies or protocols. Improvements are needed, techniques in filler composition. I'm going to leave you with this. There's a new filler that's being studied called alginous, and it's purified agarose gel. It's what agar is on Petri dishes. It appears to dissolve with saline, vitamin C, or hyaluronidase. But I saw a recent presentation that said blood could actually dissolve this. So do we have a filler that actually cannot cause filler-related blindness? Maybe. We must remain vigilant to find a cure for this devastating complication. Educating injectors on anatomy and safe techniques is the best course our industry can do. So thanks for listening.